Good evening, everyone. Today I'll be speaking on correlation of USG and CT scan in ocular lesions. The moderator for today's session is Dr. Charanya ma'am. I'll be speaking on the following topics throughout the session: the principle of ultrasound and CT scan, their common indication, and role of correlation of USG and CT scan in trauma and IOFB. So, ultrasound waves are acoustic waves having frequency of more than 20 kilohertz. In ophthalmology, generally the frequency which we use is in the range of 8 to 12 megahertz. In abdominal USG, the frequency that is used is 1 to 5 megahertz, and in UBM, which we use for anterior segment, the frequency is 50 to 100 megahertz. As the frequency increases, the resolution becomes better. However, the depth to which the tissue or any tissue can be screened, it is reduced. Ultrasound basically works on a pulse echo principle. Here, the electric current, they stimulate the piezoelectric crystals in the transducer, so the electric current is converted to the sound energy, and the resultant sound waves, they are projected on the ocular tissues, and the sound waves that are reflected from the various tissues are collected by the transducer, and they are amplified according to the strength which they receive, and finally a two-dimensional display of the tissue of interest is generated on the monitor. So the common indications for which ultrasound is done are be more in the opaque media, in which the fundus view is very hazy or fundus view is not possible, such as in corneal opacity, hyphema, cataract, pupillary membrane, or a very small myotic pupil in case of uveitis. Whereas in case of posterior segment, when there is vitreous hemorrhage or vitreous inflammation. However, in clear media, ultrasound is used for iris lesions and ciliary body lesions, and in posterior segment for tumors, for choroidal detachment, whether it is serous or hemorrhagic choroidal detachment, and for serial follow-up of hemorrhagic choroidal detachment to look for clot lysis. In retinal detachment, to differentiate between rhegmatogenous and exudative in case of optic disc anomalies, and in case of posterior scleritis. The other indications of USG is in detection and localization of IOFB, and in case of orbital lesion to localize tumors, some orbital foreign bodies, and muscle inflammation. CT scan is an indispensable tool to image ocular lesions. It helps in knowing the precise location of a lesion and facilitates planning of appropriate surgical approach to minimize the morbidity. The orbital fat provides intrinsic background contrast. Hence, most of the pathologies, they can be diagnosed without injecting any contrast material. The CT scan uses X-rays to obtain a cross-sectional two-dimensional images of the body. The cross-sectional image is produced by 360-degree rotation of the X-ray tube around the patient, and the transmitted radiation is measured by the detectors located inside the gantry like a ring around the patient. There are three scanning techniques in CT scan. First is the axial scanning, in which a single slice is obtained with 360-degree rotation of the tube. In the spiral scanning, there is rotation of the X-ray tube around the patient with continuous stable movement. And in case of multi-detector scanning, there are six slices are generated per rotation of the tube. The detectors, they measure the intensity of transmitted radiation, and based on the intensity readings, the density or attenuation value, which is also called Hounsfield unit or CT number, is calculated. The range of Hounsfield unit is from -1000 to +1000. The -1000 will appear as black and +1000 will appear as white on CT scan. Air has a Hounsfield unit of -1000, that will appear as black. Fat has -100, water has 0, soft tissue has +30 to +40 Hounsfield unit. Blood has a Hounsfield unit of 70 to 100. Calcium has more than 100. Metal has more than 300 Hounsfield unit value, and bone has a Hounsfield value of the range of 400 to 1000. Now, how to request a CT scan? The CT scan for any lesion which we order has to cover the following 7 points. First is the cell slice thickness. The available range for which a CT scan we can order is between 1 to 10 mm scans. However, for the orbital lesions, we order a 2 mm scan, and for optic nerve lesions, the scan which slice thickness which we order is 1 mm. And second is the contrast enhancement, to know the vascularity of the tumor before operating. Then third is the imaging plane. It is the plane in which we want the scan. The R in the figure, it is Reed's line, or also known as the orbitomeatal line. passes from inferior orbital rim to the external auditory meatus. The axial scan, it passes parallel to the reeds line, and all the scans are taken in this direction. The C denotes the coronal section. Coronal scan, the coronal scan is taken at an angle of 70 degrees to the reeds line, and sagittal scan can be generated after the axial and coronal scans are taken. Then comes the tissue windows. There are two tissue windows, soft tissue and bone windows. For any soft tissue disorder, the soft tissue window is ordered, and for the bone window, if any tumor is infiltrating the bone or any bone changes have to be denoted, then we order a bone window. Then there is the modification of CT scan procedures, such as in case of orbital varix, where we have to request the patient to do Valsalva during the during the time during which CT scan is the scan is being done, so that we can pick up the lesion. And simultaneous brain CT scan is done in case of tumors when there is bilateral retinoblastoma, or in case of neurocysticercosis when any orbital involvement is suspected. And 3D reconstruction is done in case of orbital fractures. The common indication of CT scan are unexplained proptosis, any ophthalmoplegia, ptosis, any palpable orbital mass, preseptal cellulitis with orbital signs, ocular surface or lid tumor with suspected orbital spread, intraocular tumors, and orbital trauma. Now we'll see the utility of BSCAN and CT scan in trauma. Some of the sequelae of anterior and posterior segment of trauma are mentioned here. In anterior segment, the common things post-trauma are hyphema, cataract, subluxation of IOL and lens, corneoscleral rupture, and cyclodialysis cleft. In posterior segment, the manifestations are vitreous hemorrhage, retinal detachment, hemorrhagic CD, posterior scleral rupture, and incarceration of retina or vitreous. So the common finding of USG in a traumatic RD, it consists of a high reflective continuous membrane with attachment to the ONH, and it shows a poor after movement, and it persists in the low gain. In case of an unexplained hypotony, when we cannot find any obvious corneal or scleral tear, then occult rupture is suspected. On USG, we suspect occult rupture when there is incarceration of vitreous and associated vitreous hemorrhage, the presence of membranous folds and textural bands in the direction of the rupture, and presence of retinal and choroidal thickening. This is the ultrasound showing multiple vitreous echoes suggestive of vitreous hemorrhage, and a high reflective band attached at the ONH suggestive of retinal detachment, and a discontinuity in the sclera with some retinal or vitreous incarceration suggestive of a globe dehiscence. So there are four choices of imaging in case of a trauma. First is X-ray. It is just used for diagnosis of a fracture, as it has very low sensitivity of soft tissue injuries. Ultrasound is excellent for imaging for globe and its contents. However, it is contraindicated in penetrating trauma, and it is done only it's absolutely essential. CT scan is a modality of choice in orbital trauma, and it is helpful in diagnosis of orbital fractures, globe rupture, and IOFB. And MRI is difficult in emergency screening, as the patient won't be cooperative and patient may be claustrophobic. It is difficult in children, and it's contraindicated in metallic foreign bodies. Now we'll see some examples. This was a case of a traumatic hyphema. A 84-year-old female had an accidental fall in the bathroom. One-eyed patient, the left eye vision was hand movement. Left eye was suggestive of whole chamber hyphema. IOP was low. There was no obvious corneal or scleral tear on examination. On USG, there was a dome-shaped membrane with multiple low reflective dot echoes in suprachoroidal space, which was suspected as hemorrhagic choroidal detachment. And similarly, the CT scan also showed a biconvex or lenticular configuration, which confirmed the hemorrhagic CD. Then in blunt trauma, there could be the injury to the lens, because the blunt trauma results in deformation of the globe, and it displaces the cornea and sclera posteriorly. The globe deformation causes the zonular attachments to stretch and potentially tear. The total disruption of zonular fibers results in complete subluxation of lens, whereas if some part of the zonular fibers are remaining, then that could be partial subluxation of the lens. So this is one example. The left figure shows a ultrasound of a nucleus drop, which shows a globular structure with high surface reflectivity in vitreous cavity. And similarly, in the CT scan, the nucleus drop is evident. And in case of open globe injury, the USG is generally avoided because due to the ocular pressure, there could be expulsion of the ocular contents. Then there would be increased artifacts in case of an irregular small globe, and further ocular manipulation could potentially increase the risk of infection before we perform any surgical wound closure. Hence, BSCAN is a routine tool after globe repair to plan for further surgical intervention in case of posterior segment pathologies. In case of a open globe injury, the CT scan on CT scan, the key finding is the decreased volume of the anterior chamber, and it clinically and on CT scan it appears as a diminished anterior posterior dimension compared to that of normal globe, which suggests that there is a open globe injury. The common finding of globe rupture are that of closed globe, which is also known as the flat tire or a mushroom appearance. There is presence of any intraocular gas or a foreign body, the thickening of the posterior sclera, and the hazy outline of the globe. In case of, now we'll discuss about IOFB. The open globe injuries are associated with IOFB in 18 to 41% of the cases. The hammering is the most common mechanism of injury, followed by drilling and chiseling, and post-traumatic IOFB reside in the posterior segment. The foreign bodies are following the penetrating trauma. They could be intraocular foreign bodies or orbital foreign bodies. Amongst the intraocular foreign bodies, they could be metallic, spherical, glass, organic material, or air bubbles. The artifacts produced by IOFB on the BSCAN, the artifacts are produced on the BSCAN because the ultrasound beam that is passed, they come across the two parallel reflecting surface, hence they produce the artifacts. First is the reverberation artifact. The reverberation artifact is identified as a multiple equidistantly spaced linear reflections that are noted posterior to the IOFB. And second is a ring down artifact or a comet tail artifact. Here, where the sequential echoes are so close, the individual echoes are not seen, and a solid echogenic streak, it appears posterior to the IOFBs. This was an experiment done by Mojahedi et al., in which they had done the imaging characteristic of intraocular foreign bodies and a comparative study between X-ray, CT, USG, and MRI, and where they artificially injected different foreign bodies in case of cadaveric lambs. And so on ultrasound B scan, the different artifacts they have mentioned, of the ring down artifact or comet tail artifact, there are two varieties. One is flashlight and second is the headlight. In the flashlight, the artifact produced is very narrow and focused, whereas in case of headlight artifact, it is very broad and dense. Sometimes the air can also mimic as IOFB on USG. In figure A, there is a high reflective echo with posterior back shadowing with a patient in supine position. It suspicious of IOFB, whereas the same ultrasound when done in erect position, we can see that the high reflective echo in mid vitreous cavity, it has shifted upwards, whereas a definite echo is seen in the inferiorly. And in the figure C, when we change the head position, the mid vitreous high reflective echo, it has been disappeared. Hence, by changing the position, one can differentiate between air and a IOFB on ultrasound B scan. This is the appearance of IOFB on CT scan. The wood appears as a low attenuation on CT scan because of presence of water and air. So they will appear as a black on CT scan. Plastic, it is moderately attenuated and it appears as of the same reflectivity of the surrounding retina, whereas the slate, bottle glass, and windshield glass, they appear as high attenuation without any surrounding shadowing, and copper and steel, they appear as high attenuation with surrounding shadowing and surrounding artifacts. So we'll discuss three cases. First, a 20-year-old male presented with a history of trauma to the left eye with stone 7 years ago. On examination, the visual acuity was 66 and 6 in right eye and 660 and 36 in left eye. IOP was 18 in both eyes. The anterior segment was normal. left eye, there was mild corneal opacity, which was noted at 6 o'clock. This is the fundus picture. The fundus picture showed a retinal fold passing through the fovea from ONH. With inferiorly, there was a presence of RP pigment degeneration, and there was a mound of retinal tissue under which the presence of IOFB was suspected. USG was done. The figure on the left shows a high reflective echo with posterior back shadowing, which confirms the IOFB. And the figure on the right, it shows the attachment of a high reflective membrane echo on ONH to the periphery, which confirms the retinal fold, which was seen clinically in the figure. A CT scan was performed. The CT scan showed a 3 mm by 3 mm foreign body in infratemporal part of the globe with Hounsfield value of 2719, which confirms that it was a more of a metallic foreign body. So as the patient had trauma 7 years ago and ERG was done to rule out siderosis, but the ERG showed the reduced photoping and scotopic responses. So there was presence of siderosis. So the patient underwent with IFB removal, EL and transcleral cryo under GA, and the metallic foreign body was confirmed with the magnet forceps. This was the post-op picture after the surgery with the gliosis seen at the region of foreign body. This was the second case. A 7-year-old child had an accidental trauma with an iron piece to the right eye. He was just an onlooker when some people were laying tent with the iron nail. The visual acuity in the right eye was PLPR inaccurate. In the left eye, it was 6.6. The finger tension was soft. And clinically, there was full thickness corneal tear with uveal prolapse. The patient had got the X-ray done elsewhere, where it showed the presence of radiopaque foreign body in the right eye. USG was done in emergency. As it was an open globe injury, gentle ultrasound was done. There was a presence of high reflective echo with posterior back shadowing, but however, the exact location was not detected. And the retinal and choroidal status was also not attempted to look for because of open globe injury. So the patient was taken for right eye corneal wound repair with vitrectomy and foreign body removal under general anesthesia. After corneal wound repair, the vitreous cavity was full of hemorrhage, and after clearing vitreous hemorrhage, the IFB was looked for in the retina, but the IOFB was not visible, and it was suspected that it might have been migrated posteriorly, and it was a case of a perforating injury. But as inferior RD was suspected, silicone oil was injected. Post-operatively, 4 days after the surgery, the CT scan was done, and the CT scan showed the presence of foreign body in the retroorbital phase, suggesting of a posterior IOFB. So in this case, CT scan helps in determining the exact location of IOFB, and instead of relying on X-ray, if a preoperative CT scan would have been done, then instead of going for IOFB removal, only primary corneal tear repair would have been the preferred surgical intervention. So previously, in the pre-CT scan era, limber rings were used and X-ray was done to locate the foreign body, whether it is intraorbital or extraorbital. The rod was stitched at 6 o'clock position, and the coronal tomographic plane was taken where the foreign body is located, and it was constructed by proportional geometric drawing method. However, it is not used now. Now the third case, 21-year-old male, it presented with an injury to the right eye with a metal particle. The patient was standing next to an agriculture machine where it was being repaired. He was diagnosed as penetrating corneal injury, and primary corneal tear repair was done elsewhere. The CT scan showed IOFB, so the patient was referred here for further management. The visual acuity in right eye was 624 and left eye it was 6.6. IOP was 8 mm Hg in right eye and 14 in the left eye. The fundus examination showed the presence of intraocular foreign body and surrounding retinal edema in the right eye, infratemporal to the fovea, and some vitreous hemorrhage inferiorly. On USG, there were moderate number of low refractive echoes in inferior quadrant suggestive of minimal vitreous hemorrhage, and a high reflective echo was noted causing back shadowing. There was retina was attached. The CT scan also showed the presence of foreign body which was impacted in the ocular codes. So it was decided to go ahead with BB, IOFB removal, EL and SOI under GA. But while tagging the muscles, some part of IOFB was seen in the infratemporal quadrant. The IOFB was actually stuck at the sclera. It was partly intraocular. So just an attempt was made to see the mobility of IOFB, and on minimal effort, the IOFB came out through the posterior wound with the help of a magnet. But as the IFB came out, there was vitreous loss also, and soon the open posterior wound was closed with the suture. Hence, if a foreign body is encroaching posteriorly, one can remove the IFB even through the posterior approach. This was the post-op picture, which showed the area of gliosis and the surrounding retinal edema. So, if a posterior approach is planned, it is better to have a pre-placed scleral sutures to avoid vitreous loss and the undue hypotony through the wound site. Now we'll look at some of the miscellaneous conditions where both are used. One is the ONH Dusan, where a high reflective echo is shown at ONH, which persists in low gain, and a CT scan appears as a white calcific deposit on the optic nerve head. Now, second pathology is a sclerochoroidal calcification. It occurs secondary to chronic CKD, chronic kidney disease, where the calcification is noted on the optic nerve and on the sclera, and on the CT scan, the multiple regions of scleral calcification are noted. Now, the differential diagnosis of ocular coat calcification on CT scan. First is a senile scleral plex, where there is scleral calcification at the insertion of medial and lateral rectors. And the post buccal, there would be calcification of the posterior coat. And the third is a thysical thysis, in which there is calcification of the posterior coat of the eye. Thank you.
Now, I think the first thing I would like to say is that you can change the format of presentation, because it was a continuous talking on your side. You try to cover so much in a very short time, So sometimes the message doesn't go through properly. I would think that we encourage participation of the audience.
Okay.
Break in between, project your slide and ask them questions. They may be your friends. I don't think they are going to find fault with you afterwards, okay? But making them answer the question, answer the other describe the photograph, etc., will have an audience participation. Otherwise, half of them may be going off to sleep while you're talking, because you are looking only at the computer monitor. You don't know even what others are doing. So I would suggest that next time onwards, at least to break the monotony, at least 2 or 3 occasions you stop, project something interesting, and let us ask 1 or 2 people to answer the questions. Okay. One point I wanted to make is that you said, go through the slides once from the beginning. Your limbal ring, let me talk briefly, because I am the oldest man in Sankanethralaya, so I can tell you that I have used limbal ring. Okay. So nobody uses limbal ring now, but if you want to know about limbal ring, basically it is sutured to the limbus.
6 o'clock.
But in lieu of limbal ring, you can also use a contact lens with radio opaque spots at 4 points, 6, 12, 3, and 9 o'clock. Place the contact lens and take an X-ray as well. But you just don't take X-ray with the limbal ring on. What you do is you ask the patient to look up, down, and straight. And all 3 are in the same film, exposed on the same X-ray film. The advantage of that is that with the movement of the ring, if the foreign body also moves to the same extent, then you know it is intraocular, okay, or maybe within the eye wall. But if it's extraocular, it's not going to move the ring at all. If it's the vitreous cavity, it moves but doesn't move as much as the ring. It moves a little less. So these are the reasons. Plus, there is a magnification factor of 1.1, which you use to draw a circle for a normal size globe.
Hello.
Then you know it's inside the globe or outside. This is all approximate. But basically, that is the theory behind limbal ring. But what is more useful and done is called Sweet's method. I don't know whether you read it. Sweet's method is not joke, it's given in many other books too. Basically, it has 2 objects which are kept in front of the eye, and then the X-ray is taken in 2 different angles. And using the angle and the distance of the fixed objects and the intraocular foreign body, you can gauge whether the foreign body is inside the eye or not. All this is history. Nobody uses it now. For the same reason, you should also have an idea about something called Roper Hall. Anybody knows Roper Hall? The guy in the UK. He had invented a probe which can differentiate between metallic foreign body, non-metallic foreign body. So it produces a ring tone when it is placed on the eye, and it's a continuous tone if it's a metallic, just continuous tone if it's non-metallic. This was used actually with various sensitivity. Intraoperative, you also try and localize the foreign body. These are all history again, but called Berman foreign body localizer. This is all history, right? So leaving that aside, now coming to the present day, there's one mistake somewhere I wanted to see. What was the mistake? That the CT, yeah, for trilateral retinoblastoma, you said CT.
Bilateral retinoblastomas.
Huh?
Bilateral.
Yeah, but nobody does CT
Nobody
scan for
does now.
retinoblastoma. Okay, fundamental to that. This is what you should understand.
I think just in continuation with what Sir was saying about the use of limbal rings and the eye movement, you can also predict whether the foreign body is in the posterior segment or the anterior segment. So if it moves in the same direction as what the radiopaque or the ring is moving, that means it's anterior, in the anterior segment. If it's moving in the opposite direction, it's in the posterior segment.
Orbital is in the brain, okay? It is retrobulbar, not retroorbital, right? So small things, but when you mention, better be specific, and then don't use abbreviations. Suppose in the examination you say with plus EL plus SY, nobody knows what is SY, what is EL and all that. Please talk in terms which are understandable to everybody. Vitrectomy, silicone oil injection, endolaser, no harm done, right? So let us try to be as communicative to others as possible, understandable by others. Okay?
Yeah.
Just a brief remarks, but otherwise it's well covered. Thanks.
Yeah, just one more thing, because what Sir has said, yes, all these things are historical importance now, but unfortunately, sometime all those medical colleges and professors, they sometime come as examiner, particularly for postgraduates. At least they need to know, because I still remember somebody mentioned something and one of our PG answer, it is outdated, we don't do anymore. I think you can't afford to say that in examination, please. Just accept and just, yes, these are methods, yes, they are newer methods, but you at least you are aware of that. That's what is more important. Nobody's going to ask you exactly how you are going to do it, because most of us are not performing, and I don't think anywhere they are practicing. Better methods are there, but just as a historic perspective, we need to know.
So, one of the points you mentioned, Akshat, that ultrasound is contraindicated in trauma. So, I think that is a little bit blanket statement, and I don't think you can say like that. You can say probably.
We already told you cannot use the word now, contraindicated.
So you can say that if it is a very severe trauma where there is a risk of expulsion of the intraocular contents, or if it is a very badly disfigured eye, then obviously it is contraindicated. You can't do ultrasound. But if it is a small wound, say it is a self-sealed corneal wound where you do suspect a foreign body, that is important. If you are suspecting a foreign body and it's a kind of a sealed wound, you can definitely do an ultrasound with proper precautions, with taking care that you don't put pressure on the eyeball, because ultrasound is immediately available to you in the emergency, which can be done, and you will know the findings immediately. Whereas for CT scan, it takes that much longer time. So in trauma, the time is of essence. The how early you intervene is really important. So if the ultrasound is possible and if it is going to give you some result, then why not to do it?
You also said something about a case being taken up on a suspicion of foreign body and then foreign body not being there. I think if an ultrasound doesn't show a foreign body, but you still strongly suspect, maybe it's good idea to have a CT scan first. Because if it's still not showing up on a CT or is in the retrobulbar space, the indication for a vitrectomy in an already compromised anterior segment view may not be there. You can defer that intervention to a later stage when the eye is much quieter. There's only one indication for MRI, which it picks up a wooden foreign body better than any other.
CT scan, yes, sir.
So if you're strongly suspecting a vegetative trauma, maybe an MRI, especially in a patient who presents with repeated fungal infections not resolving to any of her intravitreal, should strongly suspect some retained vegetative segment.